Hi, class. In the last class, we were not able to go over, um, I believe we stopped at maybe slide 20 before we jumped on to CHF. So I wanted to just go ahead and create a voiceover starting with slide 21 so that we can kind of go through the rest of this information because I feel like I didn't give you everything that you needed. Although everything is in the PowerPoints, I just wanted to expound a little on certain areas and whatnot. Something that may help you to be able to understand these cardiac disorders, make the right connections and whatnot. And anyway, without further ado, let's go ahead and start. So you're looking at this slide of sinus tachycardia. Just count the number of P's that you see here. You can count the number of P's, you can count the number of R waves in the complex, and it'll pretty much give you, once you multiply that times 10, it should give you the rate. So this is sinus tachycardia. Remember, a P wave must precede a QRS complex. And what we generally look at is the P wave, the QRS complex, and also the T wave when we are interpreting these rhythm strips. On this slide, as you can see, is sinus bradycardia. Again, there is the R waves are much more wider, as you can see. But it still has a P wave, has a QRS and your T wave. And when you look at a slide like this, one of the things you do understand is that the electrical impulse originated in the sinus area. So right now we are still dealing with all of the electrical impulses originating from somewhere in the atria, whether it be from the SA node or some other area in the sinus area or the right atrium. And we will be getting to those rhythms that originate in the ventricles, but we haven't gotten there yet, so I will let you know. All right, so placement of a pacemaker in the chest and heart leads is what you are looking at here. You should see pacer spikes before either a P wave or a QRS complex or both. Usually when it's both, it indicates that the atria and the ventricles are being paced. If not, if you don't see spikes preceding your P wave or your QRS, whichever is being paced, you want to certainly monitor the vital signs and also the patient's level of consciousness. Very important, because if they're not perfusing, if they don't have an adequate mechanical beat, then essentially they're not perfusing well to their brain. And of course, I provided a couple of YouTube videos I want you to look on here. So take a look at that. As far as patient education is concerned, these patients should keep a handheld cellular phone 6 inches away from the generator, typically found on the left side of the heart or near the heart. So phone should be on the left ear. So in other words, just place the handset on the ear that is opposite of the generator so it won't interfere with the system. These patients should avoid sources of strong electromagnetic fields like magnets and telecommunication transmitters, as they can interfere and change the pacemaker settings and cause it to malfunction. They may have to avoid MRI devices or machines depending on the technology. Apparently there's some technology out there that patients with pacemakers can still have the diagnostic test, although I'm not sure which actually. These patients should carry a pacemaker identification card from the manufacturer, and wear also a medical alert bracelet at all times, so that healthcare providers can identify um, these types of things if they are trying to initiate treatment. Knowing that the patient has a pacemaker is very important. Some patients have a combination device as well. Sometimes they have a pacemaker, which actually causes your atria and your ventricles to contract. And of course, there's a defibrillator component with these as well. And what this does is it actually shocks the patient out of a lethal rhythm if it occurs. So it's kind of a dual purpose system. Always look for bulges in the patient's chest wall, especially if you have to put those AED pads on them to shock them. You want to make sure that that pad is not directly over the generator and whatnot. So always look for that. Excuse me. You want to also assess if whenever these pacemakers are inserted, you want to assess the sites for bleeding, swelling, redness, tenderness, as well as infection. The dressing should be clean and dry over the site. The vital signs, you want them to be obviously stable and the patient afebrile. The patient will have activity restrictions, and they should increase their activity gradually. Complications from a pacemaker insertion, there is pericardial effusions, pericardial tamponade, and diaphragmatic pacing. The latter, the diaphragmatic pacing, pain at the level of the diaphragm should give you an indication that something is wrong. You want to stress also the need for follow-up appointments for reprogramming and pacemaker checks. The patient should report a heart rate that is less than that programmed in the pacemaker. So, in other words, if the physician puts settings in a heart rate of, let's say, I don't know, 75, but the patient's heartbeat is at 60, then this should be reported because apparently something is not capturing, and so this should be reported to the physician. Because that pacemaker actually it is what is aiding or causing this patient to have good cardiac output, effective cardiac output. So the physician placed a programmed the patient to be at 75 and they're not at 75, then there's a possibility that they might not be perfusing. If a pacemaker is inserted near the shoulder area, there should be no lifting overhead or lifting greater than 10 pounds for about 4 weeks. Otherwise, those leads that are attached to the heart, as you can see in the picture here, can dislodge the pacer wires. So make sure you pay attention to that. You want to ensure that, well, I already talked about that the heart rate is not lower than the pacemaker settings. And these patients should not take a shower until the surgical wound has healed. So let's go ahead and focus on another rhythm that is originating from the atrial area with the pacemaker, the SA node is located. This next one is premature atrial complexes, or what we refer to as PAC. The focus of impulse generation, it actually shifts away from the SA node to that tissue that surrounds the SA node, but within the atria. Again, these are these electrical impulses are generated within the atria, but now it's firing from atrial tissue other than the SA node, and this is why you get these early beats at times, and sometimes the P wave may look a bit different, and so forth. Um, so just remember that I said that because the impulse is not coming from the SA node, the normal, the P wave shape will be different. PACs occurs when this atrial tissue surrounding the SA node has become irritable. And so we refer to it as ectopic. So the ectopic focus fires an impulse before the next sinus impulse is due. So because it's irritated. Sometimes the P wave is hidden in the T wave and it might not be clearly visible. Now, the best way to identify hidden P waves is to look at the T wave closely for any change in its shape and compare it with other T waves because it's buried in there somewhere whenever these patients have PACs. There's usually a pause after each PAC. Now, causes of irritability is let's see, stress, fatigue, anxiety, inflammation, infection, caffeine, nicotine, and alcohol, things you want them to not consume. Also drugs such as epinephrine and also those symptomal medic type drugs, amphetamines, digitalis drugs, and also anesthetic agents. Also, what can result in PACs is when these patients have myocardial ischemia. Remember, ischemia means you're getting little blood. You are getting some blood, but little, as opposed to myocardial infarction, there was no blood flow to the extent that the tissue died beyond that occlusion or clot. Other causes, hypermetabolic states, electrolyte imbalance, also atrial stretch caused by conditions, when the atria actually stretches, caused by conditions such as CHF. Remember that all that volume of blood is backs up into the atria, causes it to stretch. And of course, because it can only handle so much capacity, only has a certain capacity, and when it stretched beyond its normal capacity, then you can have PACs. So valvular disease, these diseases of the heart valves, pulmonary hypertension with cor pulmonale. They used to call right-sided heart failure cor pulmonale. You don't hear it very much, but so just keep that in mind. The most prominent symptom is palpitations. Typically, however, these patients are asymptomatic. Want you to look at page 677, chart 34-4 for drug therapy, and know that information. Teaching includes teaching the patient to manage stress and avoid caffeine and alcohol. This causes the increased atrial, these products, they cause increased atrial, got a typo there, atrial irritability. So you want to certainly caution them to abstain from those things. Now we actually continue to deal with those impulses that starts in the atria. When you look at the word, we're looking at supraventricular tachycardia, but when you see the word supra means above. And so we're talking about impulses originating above the ventricles, which is the atria still. The P waves are not visible, especially if it's one-to-one conduction with a rapid rate. Usually these rates are pretty high, 100 to 280 beats per minute. This is due to the fact that the P waves are actually embedded in the preceding T wave, so you won't really see it. This does occur in healthy young people, especially women. How it occurs? Well, what happens is it's caused by a re-entry mechanism where the impulse circulates repeatedly throughout the atrial pathway, which is re-stimulating that atrial tissue at a rapid rate. So just think about that tissue surrounding the SA node, but again, within the atrial area. and it's just restimulating that atrial tissue at a really fast rate. Now, signs and symptoms of SVT or supraventricular tachycardia. So the signs and symptoms depend on the duration or how long the SVT lasts and the rate in the ventricular rate. That rate meaning it could be well over 100, well over 200. And so their symptoms will depend on that because, you know, as the heart beats very quickly, you don't get adequate filling time because when the heart is in diastole, normally it fills up with an adequate amount of blood, and when you squeeze, you have an adequate amount of cardiac output going throughout the body. But in the case of SVT, the heart is beating so quickly to the point that you don't get adequate filling of the ventricles, and therefore you don't get adequate stroke volume or ejection fraction or cardiac output, either one of those. All right. If the rhythm is sustained, you want to look for palpitations. These are some of the signs and symptoms. Palpitations, chest pain, weakness, fatigue, shortness of breath. These patients are nervous. There's anxiety, low blood pressure, as well as syncope. If an adequate blood pressure cannot be sustained, then cardiovascular deterioration will ensue. And this will result in angina, conditions such as angina, heart failure, and cardiogenic shock. Because again, you're not getting a good and effective cardiac output. Heart is beating too fast. All right. This is why it's so important for you to understand, as simple as it might seem, what the purpose of systole is, as well as diastole. Diastole allows the heart to rest. Everything needs to rest. So it allows the heart to rest, the ventricles to rest, so that it can fill adequately with enough blood. And of course, the systole is when those ventricles squeeze and push that blood through the aortic valve and throughout the aorta and systemic circulation. But with conditions like this, your cardiac output is impaired. If SVT is non-sustained or the ventricular rate is slower, the patient might be asymptomatic, but they might still have some occasional palpitations. These patients need a specialist. A specialist that we normally use is called an electrophysiologist. They have an electrophysiology study. The physician, we refer to them as an EPS type of physician to deal with basically the electrical problem, because this is an electrical problem, not a mechanical, although it can affect the mechanical, but it's primarily an electrical problem. Preferred treatments for this condition is what is called a radio frequency catheter ablation, and basically that the area of the atria that is irritable, they more or less kind of burn that area so that impulses can't go that particular way, or so the irritability in that area is basically disabled, if you will, and so that sometimes helps remove the atrial tissue irritability and stimulation. If sustained SVT occurs with a rapid ventricular rate, when we say rapid ventricular rate, that your ventricles are just beating very quickly. The goal is to decrease that ventricular rate, and we want to convert that dysrhythmia to a sinus rhythm, and so we end up treating the cause. Now, sometimes the doctors may do a vagal maneuver, such as they may massage the carotids and whatnot, and that can lower your heart rate. They may do vagal maneuvers, such as pressing on your eyeballs. They may tell you to bear down and hold your breath, and that usually lowers your heart rate as well. This does induce a vagal stimulation of the cardiac conduction system, these maneuvers. And so it affects the SA and the AV node, but it is a temporary intervention, so they really need to think of something more long-term with these patients. like the ablation procedure. Want you to also look at page 678 for procedures to perform the carotid sinus massage. So look at that. One of the treatments used in the acute hospital is a drug called adenosine, and this is quickly given over 10 seconds. These patients may also need normal saline. Won't always have that available. Essentially always have emergency equipment available before this drug is given, because the patient can go into cardiac arrest. So you want to have your defibrillator, the adequate drugs and fluids and so forth, just in case things go awry. Now, don't be alarmed with these patients. When you give them adenosine, it causes a flat line or asystole that can last briefly. So it's kind of scary when you see that, because you're looking at it and you're wondering when that sinus rhythm will resume again. All right. These patients may also be given atrial ventricular nodal blocking agents like beta blockers, calcium channel blockers to treat the SVT. If symptoms of poor perfusion occur and it is severe, the patient may require synchronized cardioversion or electricity in order to terminate the abnormal rhythm. There's a difference between defibrillation, because you're just shocking them, as opposed to synchronized cardioversion, where you program the machine and you see these dots over every R. And you want to do that because when that shock is delivered, it will deliver the shock. It will use the R as like a reference point, because if it's shocked anywhere in that electrical cycle, it can throw the patient into ventricular fibrillation. So the R waves kind of shows the machine where not to shock. All right, that makes sense. So we can look at some videos in class. I can show you how that procedure is done. Long-term treatments include the EPS study for the ablation procedure. Also, as I told you before, there's rapid stimulation of the atrial tissue, and it does occur with rates of about 100 to 280 beats per minute, with a mean heart rate of 170 in adults. Now, they also have something what we call paroxysmal supraventricular tachycardia rhythm, and these kind of come and then they just terminate suddenly. They don't last, they're not sustained, in other words. Let's see, and it does occur when initiated suddenly by premature complexes like the PACs. You might see this SVT. So just look out for that. If you see PACs in these patients, also look for the fact that they may have some SVT along with that. So keep an eye on that. So now we're going to get into, again, atrial fibrillation, which, again, the electrical activity or irritability is originating in the atrial area, hence the term atrial. The rhythms that you will see with these patients in atrial fibrillation are chaotic. There's no clear P waves whatsoever. In fact, the lines look more squiggly. There's an irregular ventricular response. When you start looking at the QRS waves, they're just irregular. Nothing is regular about this rhythm. Of course, when you take those calipers, as you know, remember the calipers, I trying to get it in focus, that I showed you guys, and you start walking those R waves out, which represents your ventricles, they won't be regular. This is the most common dysrhythmia. It does increase with age, and it can occur in patients who have cardiac surgeries as well. This condition causes quite a bit of morbidity and mortality in patients, largely due to clotting, because as the ventricles are just quivering and the blood is not moving like it should, then a stagnated blood can result in clotting. And so this can lead to embolic strokes and stroke symptoms. Also can lead to DVTs or pulmonary embolisms. So what happens as far as pathophysiology is multiple rapid impulses from Many atrial foci, areas of the atria, depolarizes the atria, squeezing the atria in a kind of disorganized manner. And so the heart rate in these patients can be as high as 350 to 600, believe it or not, times per minute. Now, the ventricular rate can be between 100 to 200, and this is not enough um, to sustain adequate cardiac output. Now, so the fast heart rate does result in these chaotic rhythms that you see without a clear P waves. There's no atrial contraction, and these patients lose what we call the atrial kick because the atria is not squeezing like it should. Then you're losing like 30% of the cardiac output, which could be pretty significant in people who already have a poor cardiac output or a poor ejection fraction. The normal ejection fraction is greater than 50%. So 50% of the volume in your blood is referred that gets squeezed out of the chamber is considered your ejection fraction. And again, there's an irregular ventricular response. I told you that the heart actually, or the atria, is actually quivering. It's not getting those fast squeezes, those strong squeezes that is pushing the blood through within that certain time frame. And so the reason why the ventricles beat fast is because of the numerous atrial impulses, because those impulses are coming from the atria down to the ventricles, and so this causes they're very fast in the atria, atrial fibrillation, and it causes the ventricles to beat fast as well because they are transmitting those beats, that electrical activity down below. We usually call when we're referring to these cardiac drugs, we call them upstairs and downstairs drugs. They're drugs that just treats the electrical system in the atria, which is upstairs, and they're drugs that treat those abnormal ventricular rhythms downstairs, or the ventricles. So keep those terms in mind. You may hear it again in your practice or in the clinical area, but it just kind of helps you to know if the patient has atrial fibrillation, I'm not going to give them a downstairs drug. The same, or vice versa. If the patient has a ventricular issues, you're not giving upstairs drugs or whatnot. Upstairs treats upstairs, downstairs treats downstairs, if you will. As ventricles beat fast and the rhythm is irregular, there is the ventricular filling time and the cardiac output does decrease. This leads to pooling of the blood and, of course, the risk of clotting. I told you about the DVTs and the PEs. These patients usually have an underlying cardiac disorder. The etiology and genetic risk. Atrial fibrillation is associated with atrial fibrosis and loss of muscle mass in the cardiac system. Now, the structure of the heart is changed, and it does result from this results from hypertension, heart failure, and coronary artery disease. Now, genetics also play a role. There has been about 30 genetic mutations found that could be the cause of your atrial fibrillation. Now, as the condition progresses, the cardiac output is decreased by 20 to 30%. Again, that's that atrial kick that we talked about. As far as incidence and prevalence of disease, 2.7 to 6.1 million people in the United States are diagnosed with atrial fibrillation. This happens more in African Americans and those of European ancestry. The incidence of atrial fibrillation, as I mentioned, increases with age. In older people, it can lead to CVAs and/or heart failure because all that blood is just, well, as far as the latter, heart failure, all that blood is just backing up. Can't go anywhere, and the heart has to work very hard to get all that blood out of its chambers, and so it can lead to heart failure symptoms. Risk factors for atrial fibrillation is hypertension, previous CVAs, TIAs, and other thromboembolic events. Also, acute coronary syndrome, CAD, diabetes, hypertension, heart failure, obesity, hyperthyroidism, CKD, or chronic kidney disease. ETOH is alcohol abuse, and also mitral valve disease can be a cause as well. We're moving along. And so as far as assessment is concerned, when assessing these patients, you want to ask them their past medical history about atrial fibrillation and also other dysrhythmias, because this is a recurrence. Recurrence is common, rather, I should say. Signs and symptoms to look for, again, it depends on the ventricular rate, how fast is the ventricles going, because remember, the ventricles is what squeezes that adequate blood flow or cardiac output out into the systemic circulation. So again, the ventricles are going really fast because they're getting that really fast impulse from the atria. Then of course the ventricles would beat too fast, and of course there's a reduction in the cardiac output, hence the symptoms that you will see. The apical pulse is irregular. I told you that there's a loss of atrial kick with uncontrolled atrial fibrillation. Anytime someone is in atrial fibrillation and the heart rate is greater than 100, we refer to it as atrial fibrillation with a rapid ventricular response because the ventricles are going very fast. This does result in low cardiac output, as I mentioned, poor perfusion, and these patients will have symptoms such as fatigue, weakness, shortness of breath, dizziness, anxiety, syncope, palpitations, chest discomfort or pain, as well as hypotension. These patients will need a 12-lead EKG, and of course, this is what will show that the patient is in atrial fibrillation. Gives you a more detailed view of that rhythm. Now, there is a potential for embolus formation due to the irregular cardiac system. There's potential for heart failure due to altered conduction patterns, and so these are things that we certainly want to look for. Now, the goal of care is to prevent embolus formation by restoring a regular cardiac conduction. Other goals are to restore regular blood flow through the atrium. You want to correct the rhythm. Controlling the rate of rhythm does restore the blood flow. And so this will in turn prevent embolus and also improve the cardiac output. Typically, drug therapy is effective. These patients may require anti-dysrhythmic drugs, which are used to slow down the ventricular conduction or to convert the atrial fibrillation to normal sinus rhythm. Drugs such as calcium channel blockers, cortisone, and Multag are used, and so you want to take a look at those drugs. Now, don't use this Multag drug for heart failure patients because it can exacerbate or make worse the heart failure symptoms. So make sure you recognize that. Don't also use that with patients who have a permanent atrial fibrillation, as it can increase the risk for stroke. So actually strokes and AMI and cardiovascular death. So be careful not to use the Multag in these situations. Beta blockers are used, toprol, esmolol, to slow down the ventricular response. Digoxin also controls the rate, but it does not convert the rhythm to normal sinus rhythm. So careful heart rhythm monitoring is paramount. Medications for rhythm control that may be used, flecainide, ticozin, Rhythmol, and also Covert. These drugs actually have to be administered to patients in the hospital, so it may require like a 72-hour stay in order to monitor their QT intervals and make sure they're not going into any kind of abnormal, life-threatening rhythms. Again, they can cause a prolonged QT and also sinus bradycardia, so that's why they have to be monitored. It requires continuous ECG monitoring and cardiac monitoring, again, for about 48 to 72 hours. If atrial fibrillation is permanent, Rhythm control with antiarrhythmic medications are not used. It's only used for chronic atrial fibrillation. I'm sorry, acute atrial fibrillation, not the permanent, or I should say chronic atrial fibrillation. Again, antiarrhythmic drugs are not used in these situations. Patients are at risk for bleeding when using anticoagulations, and the patient should be made aware of strokes versus bleeding. Or actually, you have to kind of weigh. It's kind of the lesser evil. You're looking at. So I put them on anticoagulations because if I don't, they may have a stroke. But if I do put them on anticoags, then they may bleed. So you're kind of weighing the difference between the two, and you can actually watch the patients, teach them about signs and symptoms of bleeding, and watch their lab values to make sure they're not too high or hypercoagulated. So most doctors, patients agree with trying to prevent stroke, so they will go into anticoagulation and watch for bleeding. When patients are on Coumadin, lab monitoring evaluation is important. We're looking at the INR. On this drug, we want to teach these patients to avoid foods that are high in vitamin K, herbs such as ginger, ginseng, golden seal, ginkgo biloba, and John's, I think it's St. John's wort. These can interfere with drug action, so they should not be given with your anticoagulations, especially like your Coumadin. Coumadin is a very common medication seen in these patients. Some of the better anticoags, such as your Pradaxa, it's a reversal, reversal drug. I don't know if I even want to pronounce it. It's idarucimab, whatever. So I won't try that again. So you'll read that in my notes. Xarelta is another one. Pixaban is another one. And also endoxaban are more effective in preventing CVAs. Now, Pradaxa side effects, it can cause hypokalemia, confusion, constipation, fever, and also pneumonia. We want to teach these patients on anticoagulations that they should report bruising, bleeding, nose and gums, and other signs and symptoms of bleeding. Now, fatigue is a common symptom with these patients, so we must instruct them to balance rest with activity so as not to overdo it. Now, nursing responsibility for cardiac dysrhythmias when patients are DC'd home. We have to do a medication reconciliation, which is a process of comparing a patient's medication orders to all of the medications that the patient has been taking. This reconciliation is done to avoid medication errors such as omissions, duplications, dosing errors, or drug interactions. So you hear that word reconciliation of the drugs or the medications when they come to the hospital. Now, as far as preventing heart failure can be prevented by restoring the normal conduction, which what you're trying to bring about is more of a controlled ventricular rate. And again, this is usually done with drug therapy. The most common treatment is electrical cardioversion, usually for stable atrial fibrillation that is resistant to medical therapy. They're going to likely use electrical cardioversion. So if the AFib is greater than 48 hours, these patients would need about well, let me back up. So the cardioversion is not done immediately with these patients, but if the AFib is greater than 48 hours, this is kind of a criteria. These patients would need at least 4 to 6 weeks of anticoagulation treatment before cardioversion is performed in order to prevent clots from moving to the heart and lungs. If there's an unknown duration of the atrial fibrillation, These patients will need a procedure called a transesophageal echocardiogram, or TEE, and it is used to assess for clot formation before cardioversion. The shock or electricity, it actually depolarizes or causes the squeezing of large amounts of myocardium during cardiac depolarization, and it actually stops the reentry circuit, those abnormal electrical impulses. It stops that, and it does allow the SA node, which is the pacemaker, to regain control of the heart, and that's what you're looking for cardioversion. You want the patient's natural pacemaker to take over. Again, have emergency equipment available. And you also, before you shock these patients, you certainly want to make sure the oxygen is off, because it can cause a spark, an electrical fire. Go ahead and also take a look at this YouTube video that I placed in your notes section. Also see page 681 under the section entitled Nursing Care After Cardioversion Includes ... to read additional information. The electricity from cardioversion can, again, it can spark a fire. So make sure the O2 is off before you shock these patients. Other treatment is left atrial appendage closure. These are for high-risk patients, for CVA, patients who can develop CVA and who are not candidates for anticoagulation treatment. There's also radiofrequency cath ablation, which is an invasive procedure used to destroy irritable focus areas in the atria as well as the ventricle conduction. It's essentially an electrical physiologic study, and what it does is it can map the location of the irritable area and ablates it or destroys the area, so you don't get impulses from those sections of the heart again. There's also a pacing procedure. Pacing helps support or resolve atrial fibrillation in patients with heart failure and also those who have conduction disorders as well. As far as surgical interventions, there's a procedure called the Maze procedure. It is an open chest technique, sometimes performed with patients who have a CABG procedure. So the Maze procedure would be done at the time that a patient is actually having a CABG. So once you confirm the areas of irritability through mapping, the surgeon will place a maze of sutures in strategic places in the atrial myocardium, also in the pulmonary artery, and possibly in the superior vena cava. And this prevents electrical circuits from developing and continuing atrial fibrillation. And so essentially, sinus impulses, they depolarize your atria before reaching the AV nodal area, and this results in preservation of your atrial kick, or that 20 to 30% that we talked about. Excuse me, class. This information here, we actually went over it already. The anti-dysrhythmic drugs that are used to slow down the ventricular conduction or convert the atrial fibrillation to normal sinus rhythm. So we won't go over this information again, but let me just check to see if I gave you everything in this area. My apologies. Yeah, so far it looks like I gave you pretty much everything here. All right, so this is an area that I don't think I covered. As far as healthcare resources, home care for assessment and health teaching is important. We must teach them about the side effects of the anti-dysrhythmic drugs and the anticoagulation. There's lots of patient education with these patients. Again, the side effects, the trade name, generic name of the drugs. The patient should report signs and symptoms of dizziness, nausea, vomiting, chest discomfort, or shortness of breath. and that they are not to stop these medications abruptly without consulting with the physician. And also how to take blood pressure and a heart rate as well is important. Other resources, these patients may be referred to cardiac rehab, cardiac exercise programs, educational programs to teach them about their cardiac condition in order to teach them better disease management, self-management, and also support groups. May provide some local chapter, American Heart Association, or provide or provincial, chapter of Heart and Stroke Foundation type of resources, such as in Canada, for information about dysrhythmias, also about pacemakers, and also CPR training, which the latter may certainly be needed. So to reiterate, these are some of the main goals. We want to remain free of embolus formation and remain free of heart failure with a regular heart rate and rhythm as well. And so now we begin to talk about those abnormal rhythms that are originating in the ventricles. Those rhythms are referred to as premature ventricular complexes, ventricular tachycardia, ventricular fibrillation, and also ventricular asystole. Now, the more life-threatening, these are more life-threatening than your atrial rhythms, because the left ventricle, remember, the left ventricle pumps oxygenated blood throughout the body to perfuse vital organs and tissues. So when the ventricles are sick, you got a major problem. All right. So these patients should avoid illicit drugs that can stimulate the heart of these patients who are high risk for these deadly rhythms. So anyone with, well, any kind of rhythms, but especially those originating in the ventricles, should avoid drugs. Can kill them. So here is a ventricular dysrhythmia here. This is a unifocal PVC, and it's called unifocal because the complex, the abnormal or bizarre-looking complex look alike. So they do originate from the same area in the ventricle. And there's also what we refer to as a normal sinus rhythm with a multifocal PVC. And as you can see, both of these PVCs just look different. So they are multifocal. They're coming from different focus areas in the ventricles as well. So there's unifocal and there's multifocal. Unifocal, they look alike. Multifocal, they look different. But yet they all come from the ventricular tissue. Now, your premature ventricular contractions, or PVCs, there's increased irritability, ventricular cells, and seen as early ventricular complexes, and they're followed by a pause. You see a pause in the electrical rhythm on your strips. PVCs can be either unifocal or multifocal. They're classified by different types, and they come in repetitive rhythms. And we did talk about the bigeminy, trigeminy, quadgeminy. And also there's two sequential PVCs. They're referred to as couplets. And there's also three or more successive PVCs called non-sustained VTAC. Again, if they come three or more, and they're not really sustained, they may kind of come and go. I refer to these as non-sustained VTAC. And the frequency, of course, increases with age. They do occur in conditions like AMI, CHF, COPD, anemia, and they also are seen in patients with a low potassium and magnesium. So you're looking at those labs in a clinical setting. Causes of PVCs, symptomal, mimetic agents, anesthesia, drugs, stress, nicotine, caffeine, alcohol, infection. Now, with the nicotine, caffeine, alcohol, you automatically know in your patient teaching that you're going to teach these patients to avoid those products. It also can occur with surgery, and again, especially with older people. Postmenopausal women also experience PVCs and palpitations with caffeine. So as far as interprofessional collaboration, collaborative care, these patients will experience palpitations or chest pain caused by the caused by an increase in your in the stroke volume of a normal beat after a pause. And so, because of the PVCs, peripheral perfusion can be compromised. So this is why we're checking our periphery, your extremities and whatnot. So you're checking your radial pulses, your pedal pulses, to see if they're perfusing. If they have a beat, then you know they're perfusing, even though they have the PVCs. Again, this can compromise your perfusion. Hence, you get very little heartbeats, not heartbeats, but pulses as a result. And so your pulses in your periphery, again, pedal, radial, may be diminished. So always check those peripheral pulses to inform you about perfusion status. You can also assess the carotid, the brachial, and femoral arteries as well, checking for a pulse. This is how we check for perfusion to these areas. Treatment is to help eliminate stress. We want to replace the magnesium and potassium supplement with supplements. If the rhythm persists for greater than 24 hours and it is excessive, these patients are given beta blockers in order to slow down that heart rate and to control that rhythm. So we're looking at the electricity part of the system as well. This is called VTAC, ventricular tachycardia, another downstairs rhythm issue. This is repetitive firing of irritable ventricular ectopic focus, and usually at a rate of between 140 and 180 beats per minute is what you will see. This particular beat, I believe, is 166. All right, and the VTAC may occur from the automaticity or reentry mechanism. Remember the automaticity we talked about in some of the previous slides. It's one of the characteristics of the heart. So just take a look at that definition. They can be intermittent, which is referred to as non-sustained, or they can be sustained, lasting longer than 15 to 30 seconds. If it lasts for more than 15 to 30 seconds, then it would be referred to as a sustained VTAC. It does occur in patients with IHD, or I believe that is, I want to say idiopathic heart disease, but it's some form of heart disease. An MI, a cardiomyopathy, hypokalemia, hypomagnesemia, valvular heart disease, heart failure, drug toxicity, such as steroids, and also hypotension can cause this condition as well. Can also occur in patients who use cocaine or illicit inhalers. Patients who experience cardiac arrest usually have VTAC first. Then it deteriorates into a ventricular fibrillation as the terminal rhythm. So the faster the rate of VTAC, the more signs and symptoms these patients will have. The slower the rate, the better tolerated. Now, ACLS guidelines recommend electrical conversion, cardioversion, and also drugs that might be used with these patients are mexiletine or sotalol to prevent reoccurrence. If these patients are taking digoxin, you would need to DC for 48 hours before cardioversion. So a couple of days before you're going to cardioverse these patients, DC the digoxin. Because DIG increases irritability and places the patient at risk for ventricular fibrillation. Remember, the ventricles are just quivering in ventricular fibrillation, and this will occur after the counter shock. Radiofrequency ablation, remember, we're burning those little areas, or destroying those areas of irritability whether it be in the ventricle tissue or atrial tissue. And they do this for ventricular tachycardia at times. Now, unstable VTach that does not have a pulse, again, unstable VTach, because sometimes with VTach you can have a pulse and sometimes you don't have a pulse. Unstable VTach without a pulse is treated the same as your ventricular, your VFib, or ventricular fibrillation. VFib. So the treatment of choice is defibrillation. Not cardioversion, but defibrillation. So you're just going to shock them with high joules of electricity. Make sure no one is in contact with the patient or the bed, as this can lead to shocking of those individuals. And always think about CAB or remember it used to be ABCs, airway, breathing, circulation, and of course the new guidelines are circulation, airway, breathing with these patients. I think on some of your old tests that has not been updated, you still might see ABCs. So keep an eye on that as well. So here's probably one of the most lethal rhythms. This is what we refer to as a coarse ventricular fibrillation. And it is because you see these squiggly lines, they're more coarse. They're not that fine, kind of smooth look, more kind of jagged, if you will. Impulses, they're coming from many irritable areas in the ventricles. They're totally disorganized, and it results in an absence of a ventricular contraction, meaning there is low to no cardiac output. On an ECG, there are no recognizable deflections. You know, like the QRS is pointing up, the P waves, or sometimes depending on which lead you're in, they can be pointing other different ways. But anyway, in your ECGs, when you look at them, you don't see anything. They're unrecognizable. It's too fast. The ventricles are basically quivering and they're using a lot of oxygen because the heart is just working too fast. No cardiac output, no pulse. There's no cerebral, myocardial, or systemic perfusion whatsoever. If they're not terminated within 3 to 5 minutes, the rhythm is fatal. It's essentially like not having a heartbeat at all, and you're not getting perfusion. Remember, the brain and so forth dies within about 5 minutes. So, ventricular fibrillation is sometimes due to patients who have coronary artery disease. AMI, heart attack patients are at greatest risk. Can also occur in the following patients, patients with a low potassium and magnesium. Again, watch those labs. Also can occur in patients with hemorrhage. Also drug therapy, rapid ventricular tachycardia, shock, surgery, as well as trauma can occur. Signs and symptoms of ventricular fibrillation: the patient faints. There's an immediate loss of consciousness. There's pulselessness. These patients are apneic, or they're not breathing. There's no blood pressure. There's no heart sounds. These patients will go into, because they're retaining all this CO2 and they're not breathing, respiratory first, and then metabolic acidosis can develop. These patients can also have seizures. The pupils become fixed and dilated. They're essentially dying. The skin is cool and mottled. Then it essentially leads to death. Treatment is early defibrillation in order to convert to an organized rhythm. And this is an ACLS guideline. If defibrillation devices are not available, then high quality CPR is performed until the AED arrives. Class 1 to class 4 antidysrhythmic drugs are used, such as your procainamide, beta blockers, amiodarone, and calcium channel blockers. A life-threatening VTach can also occur that is called torsades de pontis. And if it does occur along with this condition, then the patients are treated with magnesium sulfate. We didn't give you guys torsades de pontes in this particular study, but you'll learn about a lot of that, especially when you get into the clinical practice setting. But it essentially is a kind of ventricular fibrillation. It results from that, and of course, again, the magnesium sulfate is the treatment of choice. Here's what we call ventricular asystole, with one idioventricular complex that you see. With this rhythm, there's no ventricular depolarization, meaning the ventricles are not squeezing. There's no QRS complex, no contraction of the ventricles. There's no cardiac output, no pulse, no respirations, no blood pressure, no perfusion to the systemic circulation. The patient is essentially dead. The SA node might be firing, but it cannot conduct to the ventricles. So the entire electrical and conduction system is silent. This can result from myocardial hypoxia, so low oxygen to the myocardium or the heart, muscles of the heart, also possibly due to heart failure, also caused by severe hyperkalemia and acidosis. These patients are in cardiac arrest. There's no cardiac output, and so the underlying rhythm of a VTAC, VFib, or asystole is occurring. And so without a cardiac output, the patient is pulseless, and the level of consciousness is poor due to poor cerebral perfusion and gas exchange. The respiratory, their respiratory arrest usually is followed by, well, usually they have respiratory arrest first, and then cardiac arrest occurs afterwards. Remember, you can't be breathing without a heart beat, but you can have a heartbeat without breathing, but it just won't last very long at all. So keep that in mind. CPR is needed to prevent brain damage and death in these patients. Now, we must initiate BLS as well as ACLS protocol. So go back to your BLS course. Don't expect for you to know much about ACLS. That's more for more seasoned nurses who are working in the clinical setting. Remember, CPR priorities change from the ABCs to the CAB. So there's compression, airway, and breathing. So be familiar with the BLS on page 686, I believe. So continue chest compressions until defibrillation is ready. There's something called the asynchronous countershock, what's also called asynchronous countershock. Always resume the CPR after the shock. You want to keep that blood flow, perfusing of the body as much as possible. Families are not allowed to remain at the bedside during resuscitation attempts, but I've seen different, so I'm not sure where that came from. Let's see what else I got for you. And we talked about the AED, so I won't go over that again. We talked about it. There's also a video that I listed for you as well. But the patient does have a greater chance of survival with an AED or electricity, so it must be obtained as soon as possible. And of course, this AED device allows laypersons to effectively respond to cardiac arrest, something that was not in place, obviously, some years ago. And so this is it, actually. This is just a case study. Go ahead and make sure you read these as well. I'm going to post this on the tile, and you will have an opportunity to hear this information, and hopefully it will make a difference as far as being able to connect the dots. Thank you, everyone.